All right. Welcome to Chemical Analysis of Urine, Part 2. So we are going to start with urine, blood, and hemoglobin. So when we look at urine, blood, and hemoglobin, the presence of blood can occur because of damage to upper or lower urinary tracts. We can see hematuria arising from the glomerulus, the renal tubules, the ureters, the bladder. The presence of intact red blood cells is termed hematuria. We don't necessarily see red cells available in the urinary sediment, in dilute urines, or urines with high acid or alkaline pH. The hemoglobin in the red cells will cause a positive reagent strip reaction. Free hemoglobin can also yield a positive result, and this can come from intravascular hemolysis, and they'll enter the urine as a filtrate of plasma through the glomerular filtrate. It is also called hemoglobinuria. We can also see something called myoglobinuria. Again, we'll find this come through the glomerular filtrate, and this is basically coming in because of muscle damage. So detecting urine, blood, and hemoglobin, we use a peroxidase reaction, or peroxidase-like reaction because of hemoglobin. So typically our peroxidase with a chromogen in the presence of hemoglobin and peroxide, you'll get an oxidized chromogen and peroxide. So basically, hemoglobin and myoglobin will catalyze oxidation of the chromogen by an organic peroxide in the reaction. And we will read this two different ways. So we can read it negative, non-hemolyzed trace, or non-hemolyzed moderate. So this will look like a speckled pattern, or hemolyzed, where you'll see trace is this slight yellowy color, then to a greenish to greenish blue. So most of our dipsticks are capable of detecting whole red blood cells as well as free hemoglobin and myoglobin. So the red cells that are intact will hemolyze on the test pad. So basically you'll get this freed reagent, freed hemoglobin reacting with the reagent. So you'll get that green spots or speckled pattern on that yellowish orange background. And then the red cells then obviously will look spotted. If there's many of them, it can cover just the whole pad and it'll look like hemoglobin or myoglobin with that free uniform green or dark green blue color. Typically we're reading it around 60 seconds and the color changes from orange to green to a dark blue. There's again those separate color scales based on intact versus hemoglobin or myoglobin, and the results are reported as trace or moderate numbers of intact red cells or trace through large amount of hemoglobin. So urine, blood, or hemoglobin false positives can come again with oxidizing contaminants like your hypochlorites or high bacterial content, because bacterial peroxidases will actually cause that enzyme reactivity. False positives will also occur if it's contaminated with menstrual blood, and if there's contamination with betadine as well. False negatives, inadequate mixing, so all the red cells are at the bottom, or sediment. Formalin, vitamin C, capoten, high specific gravity, nitrites, and proteins can all cause false negative results. So what's the significance? So normally urine is free of hemoglobin, red cells, myoglobin. So a positive test needs to be followed, obviously, by figuring out what is the exact cause and origin of this abnormal finding. So we can look at the correlation, and this is typically what we want to do when we're looking at a macroscopic and then the chemical macroscopic and microscopic combination. So if we are seeing this, we want to then go follow up with a microscopic examination. Are there red cells present? Does it agree with the intensity of the chemical test? Are there red cell casts or hemoglobin casts? Are there ghost cells, or those empty red cell membranes? Are there many squamous epithelials, because that could indicate possible menstrual contamination? And we can see hematuria, hemoglobinuria, and myoglobinuria either by themselves or together. So it's important to ask all these questions as we're looking at our microscopic. And we'll talk more about that when we talk about the microscopic analysis of urine. So hematuria is the presence of blood or intact red cells in the urine. So a urine that's highly alkaline or has a very low specific gravity can cause the red cells to lyse, so it'll release their hemoglobin into the urine. This is still considered to be hematuria as far as origin, but we can't truly distinguish true hemoglobinuria with this type of hematuria. So when the lysing occurs, microscopic examination can either show no red cells or the empty red cell membranes or our ghost red blood cells. In microhematuria, there's a small amount of blood in the urine, so the color of the specimen is unaffected, and we can only detect it chemically or microscopically. But gross hematuria will alter the color of the urine, and it's easily visible macroscopically because it'll look pink or red. So what's the significance? So it can indicate renal diseases, whether it's glomerular, tubular, interstitial, or vascular. We can also see it in patients with lithiasis or kidney stones, UTIs, urinary tract tumors. We can see free hemoglobin from intravascular hemolysis if there's incompatible blood transfusions, hemolytic anemia, severe burns, cold autoimmune anemia, and those that have been electrocuted. And lysis only in urine is not as significant as this type of free hemoglobin. But with this type of free hemoglobin, we're going to see a lot more signs and symptoms. So we can see myoglobinuria with severe damage to skeletal or cardiac muscle from crush injuries, shock as well, and myocardial infarctions. So basically, this is the heme protein of striated muscle. So this is the reserve supply of oxygen. It'll help with the movement of oxygen within the muscle. So injury to these muscles can release myoglobin into the circulation. Even just a subtle injury to muscle cells can actually cause the release of myoglobin, and we can detect it in the urine. It has a molecular weight of 17,000, so it's easily filtered through the glomerulus and excreted into the urine. It's cleared very rapidly from circulation, so the plasma is typically uncolored, even though the urine can show red to brown to black depending on the degree of myoglobinuria. We can also see, this is something that's evolved over the last, I want to say, decade or so, when we started seeing increased overdoses of heroin simply because we're finding fentanyl and carfentanil being laced with the heroin that's out on the streets now. We can start really seeing signs and symptoms of a overdose, including myoglobin present in the urine in significant amounts if someone has overdosed on heroin. And I mean, we're talking overdose where they've had to be resuscitated, Narcan multiple times, things like that. So blood versus hemoglobin versus myoglobin. They'll all produce positive reagent strips as blood. Macroscopic differentiation, red plasma plus red urine is usually hemoglobin. Clear plasma plus red urine is myoglobin. And we can do ammonium sulfate to differentiate chemically as well. But again, not something we do as commonly. All right, so now we have urine bilirubin. So this is formed by hemoglobin degradation. It's bound to albumin, transported through the blood to the liver. Unconjugated bilirubin is insoluble in water, can't be filtered through the glomerulus. It's usually conjugated with glucuronic acid in the liver to form bilirubin diglucuronide. This conjugated bilirubin or direct bilirubin is water soluble. It's excreted through the liver, through the bile duct, and into the duodenum. Small amounts of conjugated bili are regurgitated back from the bile duct into the blood system. It's filtered through the glomerulus and it excreted in the urine whenever plasma levels increase. So typically, we are not going to detect bilirubin in the urine in a normal individual. So we use diazonium salt to detect urine bilirubin. So typically it's a coupling reaction with the diazonium salt with bilirubin in an acidic medium that produces azobilirubin, which is a color chain that produces a color change. So you got your bilirubin plus your diazide in an acidic environment. You'll get your azobilirubin formation, and your color change will vary between tan to tannish purple, and the colors will correspond to bilirubin from negative to large, or 1 plus negative, 1 plus 2 plus 3 plus, depending on your lab. And we're typically reading around 30 to 60 seconds, depending on your manufacturer. So false positives for urine bilirubin, we don't read it at the right time. If there's other color reactions from indican, lodine, thorazine, or phenazopyridine that can cause abnormal color reactions, we will confirm these with an icto test, and we'll talk about that process as well. False negatives, ascorbic acid will decrease the sensitivity if there's high levels of nitrite, or if it's been exposed to light and room temperature. Bilirubin will oxidize to biliverdin because bilirubin is unstable under light exposure. So your bilirubin confirmatory test is your icto test. So we use an asbestos pad and the reagent tablets. So basically it's the same diazo reaction, but it's more sensitive because it can detect as little as 0.05 milligrams per deciliter. So if we have bilirubin confirmation, or we just need to do bilirubin, we're going to, test that as well. It's a good confirmatory test for positive dipstick, and it will have your 2,6-dichlorobenzene diazonium tetrafluoroborate, which is the diazo, the sulfosalicylic acid, and sodium bicarbonate. The mats are this asbestos cellulose mixture. When urine's placed on the mat, the absorbent qualities of that mat will cause the bilirubin to stay on the surface. Everything else will go through the mat. And the sulfosalicylic acid gives that the acidic environment that this reaction needs. And it will act as the sodium bicarb to provide effervescence, which helps partially dissolve the tablet. And then the salt couples with the bilirubin on the mat, and you'll get a purple to blue reaction. So it's basically putting, and we'll do this in the lab. I'm pretty sure we have some. It's not, we had them, they weren't available for a very long time. But basically you put a drop of the urine, or a drop of water to bubble it up, drop of urine, and it spills over and creates that blue color. So, or blue-purple color, I guess you call it. It's purple. I don't know. I have trouble with the color on that one. So urine bilirubin, why do we care about it? So typically we're not going to see it in urine. We will see it in urine if the bile flow to the colon is obstructed, if there's liver damage, if there's hepatitis or cholestasis. This leads into urobolinogen. So this is formed from bilirubin in the intestines. So urobolinogen is colorless. It will oxidize to urobilinin, brown. Most of it's lost in the feces. 10 to 25% is reabsorbed into the blood, returns to the liver, and re-excreted into the intestine. A small amount of this urobolinogen is excreted by the kidneys into the urine. So normal levels are less than 1 Ehrlich unit, or 1 to 4 milligrams per 24 hours or less. So we will use an Ehrlich aldehyde reagent. So that's your p-dimethylamino-benzaldehyde, and urobolinogen will create an azo dye. So it's literally just a simple color development. So the aldehyde or diazonium compounds will react with that urobolinogen. It'll produce a pink or red color in an acidic environment. Typically we're reading at 30 to 60 seconds, again depending on manufacturer, and it will display a range of colors in that pink spectrum from light to dark. Most will show 2 blocks on the color chart for normal levels of urobolinogen, so 0.1 and 1 milligram per deciliter, and then others of 2 to 8 to 12 depending on the manufacturers. So false positives, we can see in the presence of your p-amino salicylic acid, sulfonamides, phenazopyridine, porphobolinogen. We can use a Watt-Schwarz test to differentiate, but again, this is not something that we commonly do within the laboratory or just the routine clinical laboratory or hospital laboratory. False decrease in urobilinogen. A true absence of urobilinogen is not detectable, but we can see false negatives with broad-spectrum antibiotics, nitrite, formalin, and we didn't store it correctly because we can see the oxidation of urobilinogen to urobilinin. So what do we care about this? Well, normally it's present in low amounts, peak levels between 2 to 4 parts per PM, 2 PM, not parts, sorry. It's elevated in things like liver disease, intestinal obstruction, hemolytic anemia, and hemolysis. Nitrate. So nitrates are normally present. Nitrates are then converted to nitrite by bacteria. So this reaction takes up to 4 hours to complete. And this reaction is only going to be present if we have nitrate-reducing bacteria. So patients that have a UTI with a non-nitrate-reducing bacteria, this strip test will be negative. So nitrite. Sorry, this is the hardest one when you talk fast. Nitrite will react with the p-arsenilic acid to form a diazonium compound. This then couples with the quinoline compound. It'll produce a pink color in the reaction. They're read at 30 to 60 seconds, depending on the manufacturer. Any degree of uniform pink will be interpreted as a positive nitrite, and the presence of 105 more organisms per milliliter. Color development is not proportional to the number of bacteria present. Pink spots or pink edges are not a positive result. If the uniform pink color is very light, you might want to put a white against a white background, and we report it as positive or negative. So here you go, your reaction A, your nitrite and your p-arsenilic acid forms that diazonium compound, and then your 3-hydroxyl 1,2,3,4 tetrabenzquinolone diazonium compound will equal that pink color. So reagent strips for this commonly use that p-arsenilic acid and quinoline compound. False positives, well, you leave it at room temperature and the bacteria multiply, or the phenazopyridine is present. False negative, they have non-nitrate reducing pathogens, hasn't spent enough time in the bladder. They don't have enough nitrate in their diet. Nitrite was converted to nitrogen. Elevated urobolinogen or ascorbic acid can also cause false negatives. So what's the significance? We only use this as a screening method. We don't replace micro procedures with this. So if there's clinical symptoms, bacteriology tests, so we have to do culture and sensitivity, should be performed even if the nitrite is negative. All right, leukocyte esterase. So this is present only in neutrophils. Few neutrophils can be seen in normal urine. An increased number of newts will indicate that there's a urinary tract infection. So screening for UTI will include pH, protein, and nitrite. Mix the specimen well and test it at room temperature. Because remember, esterase ends in A's. That means it's an enzyme. You don't want it cold. So neutrophils will have these esterases. They can be detected by reagent strips. Each of these will have an appropriate substrate, like your indoxyl carbonic acid ester. It's based on the reaction that we're going to see in the next slide. The reagents are used will vary between manufacturers, but we read them at 2 minutes, and a positive reaction produces a lavender to purple color, and we report them from negative to trace to large, and values reflecting cell numbers from negative to 500 can also be reported, and these may not correlate with the number of neutrophils seen during the microscopic examination. So here with your leukocyte esterase, you have indoxyl or pyrrole carbonic acid ester in the presence of the granulocytic esterase or leukocyte esterase will produce an indoxyl or pyrrole, and then the indoxyl or pyrrole with the diazonium salt will create that purple color on that reagent pad. False positives, again, with oxidizing agents, contamination by vaginal discharge, if formalin is present, drugs that have imipenem, metropenem, or clavulanic acid. Nitrofurantoin can contribute a color that can cause misinterpretation of the results. False negatives, high specific gravity, and in urines that have glucose and protein, the white cells will crenate and they can't release their esterase. We can also see false negatives again with ascorbic acid, oxalic acid, some other, and all kinds of different drugs as well. Other chemistry parameters, calcium, creatinine, microalbumin, ascorbic acid can all be analyzed, but typically we're doing these on an automated platform. And these, well, actually, hold on, let me go back. So calcium, creatinine, microalbumin, ascorbic acid, we will do these in chemistry. Calcium, obviously, urine calcium, if we have an excess amount of calcium. Creatinine will kind of tell us the filtering function of the kidneys. Microalbumin can be a nice early indicator of kidney damage. Or damage to the tubules, and we can pick this up before anything else. So they'll routinely screen that on older adults over 50, and ascorbic acid again because it can contribute to so many false results. So all of our dipsticks, we can do rapid simultaneous determination of commonly measured urine substances, and abnormal urine chemistry results will help in assessing our renal disorders, but can also disclose many different systemic disorders, and it can be really helpful to the doctor. And we all obviously have to make sure that we adhere to manufacturer instructions to avoid reporting of misinterpreted results. So your lecture code for chemistry part 2 is 2432.